I'm going to be talking to you about optimising use of antimicrobials, particularly focusing on sort of national policies around this. So the reason why I'm here is that a couple of years ago, or a few years ago, the government produced a report called the National Over-Prescribing Review about generally trying to tackle the over-prescribing of medicine, recognising medicines do a lot of good, but also can cause some harm. And antimicrobials are part of that, but the particular focus on over-prescribing in, for example, older people or people on dependence forming medicines. But I was appointed National Clinical Director to oversee the recommendations of the review, and I've been involved with colleagues like Kieran Hand on the antimicrobial side too. I don't need to tell you that antimicrobial resistance and antimicrobial stewardship are important issues, and it was in the Lord Darcy report mentioning the looming threat of antimicrobial resistance, which could kill 10 million people globally each year. And yet we're doing quite a lot, I think, in our country, and you know, you'll see some examples of this, but there's still more that we could do to decrease inappropriate antibiotic use and accelerate development of new diagnostics and drugs. So I'm particularly going to focus on the HM Government Antimicrobial Resistance Action Plan, which was published about a year ago, and this is the second 5-year plan. And one thing to point out is the burden of infection and antimicrobial resistance. So 87,000 deaths per year involve bacterial infections, but you'll see that a substantial proportion of those are actually associated with antimicrobial resistance or actually attributable to antimicrobial resistance. And you see how this compares with some of the other things that we particularly think of in terms of causes of death. In terms of burden of bacteremia, there's been no net change in the burden, but there has been a 3.5% increase in resistant bacteria. And in terms of the National Action Plan, we've got 4 themes and 9 strategic outcomes. So in terms of the themes, we're trying to reduce the need for and unintentional exposure to antimicrobials, optimising the use of antimicrobials, investing in innovation, supply and access, and being a good global partner. So I'm particularly focusing on the optimising use, the second of those, and I'll be giving quite a number of examples of that. So here's some of the targets. So by 2029, we aim to reduce total antibiotic use in human populations by 5% from the 2019 baseline. And also by 2029, we aim to achieve 70% of total use of antibiotics from access category, the new UK category across human healthcare system. Now it's my colleague Kieran who put these slides together. He was very proud of himself. It took him a very long time to produce this particular slide. So this is arrow. So avoid need, reduce demand, reduce exposure, optimised choice, weigh impact, and in relation to that, we're looking at improved clinical outcomes, better patient experience, reduced threat of AMR, less wasted resource, and lower carbon footprint. By the way, we're happy for these slides to be shared because I'm aware I'm going through them fairly quickly, and some of the ones coming up have some very, very fine print, which even I struggle to see. Just hold on a second, let me just... So in terms of the prescribing and medicines optimization, we've got those strategic goals which I've just mentioned. There's the behavioural change enablers, which I'll be talking about a bit in a moment, and the priority action areas, which are overprescribing in general, paediatric antimicrobial, shorter courses, recurrent infection, antibiotic sparing strategies, backup prescribing, narrow spectrum antibiotics where appropriate, IV to oral switch, and penicillin allergy delabeling. So in terms of workforce and capacity, then one of the important things that's been around for some while is the target training implementation programme. So this is a partnership between UK Health Security Agency and NHS England and Imperial College. It's about implementing the target toolkit in primary care networks using a train-the-trainer approach coupled with fast-track mass training events and followed by academic evaluation. So an important resource. Then also, in terms of knowledge mobilisation, there's the Pisces blueprint. So these are a series of blueprints for audit and quality improvement. They're developed in partnership with GPs and Integrated Care Board, Medicines Optimisation teams, and they're for adaptation according to local policies. And these published 8th of April 2025 on Future NHS. Digital vision. So digital can help us quite a lot here, thinking in terms of, say, as prescribers, for encouraging us to, for example, prescribe short courses, trying to encourage people not to have prolonged IV courses in hospital, for example. So we've got a digital vision for AMS and best practice framework, and it's been developed from surveys and focus groups and interviews with frontline staff. And we're aiming to identify the digital system functionality required to support effective and efficient antimicrobial stewardship. And this was also published on the 8th of April. Then in terms of commissioning, there's some exciting work in terms of community pharmacy teams incentivised to use the target toolkit leaflets for responding to symptoms and counselling patients presenting prescriptions for antibiotics. So giving some education around those. So we see being given information out in relation to symptoms of UTI, respiratory tract infection, and an antibiotic checklist. And we think there's been over 11,000 additional influenza vaccines were delivered and prompted by discussion using the antibiotic checklist. And in terms of governance, then in collaboration with the CQC, Medicines Optimization team, we're aiming to support ICBs to identify and meet requirements of the Health and Social Care Act and to demonstrate appropriate antimicrobial use and stewardship. And that was published in January of this year. Board Assurance Framework for IPC was updated in April. So just looking at some of the action areas in terms of over-prescribing, I don't think we need to tell you that there's a potential issue or a major issue here. So it varies twofold across primary care in England, adjusted for age, and UK antibiotic consumption per inhabitant is double that of the Netherlands and 50% higher than Sweden. Obviously, there are some countries where we're doing better, but you know, I think it's worth comparing ourselves to those countries. And obviously, it's important because this drives resistance and can increase reconsultations, ED attendance, hospital admission, length of stay, and indeed mortality. So a number of ways in which we're addressing this. I'm not going to go through all of those, but includes, for example, the target training implementation and dashboards that we've got in various systems. In terms of what's going on with antibiotics, then we've had a couple of blips around this, but in the last year, in primary care, then things do seem to be going down a little bit, and also going down a little bit in secondary care. Obviously, we've had COVID and other things that have potentially influenced this, but I think we are slowly heading in the right direction. In terms of paediatrics, percentage of children aged under 10 exposed to antibiotics per year has actually increased from 27% pre-pandemic to 36% post-pandemic, which is obviously a concern. And it matters because obviously exposure is going to increase antibiotic resistance, but it's also associated with a range of other problems which we've highlighted on this particular slide. And the target toolkit and other resources can help us try and address that. So we've got various outputs, and I'm not going to go into this in detail because you really are not going to be able to see this. But we've got an NHS performance framework. We've got information on EPACT, which is a data source for prescribing in primary care. And then we've also got Prescribing, which is an organisation which provides, well, data and support to mainly colleagues in primary care. So it's showing considerable variation across the ICBs. In terms of shorter courses, so research demonstrates safety and effectiveness of shorter antibiotic treatment courses, but wide variation is evident in primary care in England. So each additional day of antibiotic treatment is associated with a 4% increased risk of side effects and 3% increased risk of infection. But I think we are starting to get that message through. I know from a GP perspective it can, and it must be the same in hospital, it can feel like, oh, this person's got a really bad infection, or the patient themselves say, oh, I really needed the 7-day course last time. But I think we are getting the message through about the fact that in general these shorter courses are as effective. There's some information on future NHS on various strategies in terms of addressing course length. And on the right, the key thing about that graph is what's happening in green there, and the green bars are sort of showing that over time we're getting an improvement from 30% 5-day courses in January 19 to 70% in January 2025. So that really is quite a substantial improvement. So as I say, the message is getting through there. In terms of recurrent infection, it's interesting that 10% of antibiotics are for just 0.5% of registered patients who experience 10 or more episodes of acute infection per year. So again, in general practice, these might be patients who with COPD exacerbations, for example. And obviously, recurrent infections can have a detrimental effect on quality of life for patients, but it exposes them to antibiotic side effects and risks of resistance. So various ways in which we can try and control that, I think, are important. So there's toolkits created for clinical review of patients with, say, UTI, COPD and acne. Acne is an area I'm quite interested in, and just trying to see if we can use non-antibiotic treatments as far as possible. I'm not saying we should avoid antibiotics completely, but the evidence is that many patients can be managed with non-antibiotic treatments. So we've got the target resources on the Royal College of GP's website. There's a recurrent UTI review checklist, and again, certainly as a GP, I've sort of noticed that my change in knowledge and behaviour in recent years has meant we've got better control. For example, using estrogen creams with women, older women who have recurrent UTIs, can often make a really big difference and avoid multiple courses of antibiotics. Having good reviews of COPD patients can actually potentially reduce by about 50% recurrent exacerbations per year, and therefore reducing antibiotics. And then the antibiotic sparing strategies. So research demonstrates antibiotics offer limited benefits to patients with mild self-limiting conditions in primary care, and alternatives to antibiotics are available for symptom relief. So clearly it's the thing that makes sense to avoid antibiotics if possible. And there's been some interesting things here. First of all, the graph on the left demonstrating that, for example, amoxicillin doesn't provide clinically meaningful, important benefit for symptom duration among children presenting with uncomplicated lower respiratory tract infections. And then the new Pharmacy First scheme, which I think many of you will be aware of, Pharmacy First for 7 common conditions. Community pharmacies being encouraged using protocols to see patients with a range of different conditions. And in their toolkit, there often are antibiotics, but first it's often the case of trying something different. So if I've got it with sinusitis, trying steroid nasal spray, so that being offered to 44% of patients, and with 40% of patients with otitis media being supplied with anaesthetic eardrops. So, you know, it's great to see those changes. And then encouraging narrow spectrum antibiotics. So the United Nations General Assembly set a global target to reach 70% of antibiotic prescribing from narrow spectrum. And of course it matters because, and you will all know this, but broad spectrum antibiotics cause unnecessary, what we could call collateral damage to the microbiota, leaving patients vulnerable to opportunistic infections such as C. difficile, diarrhea. And so, where possible, should be held in reserve for treatment of infections resistant to narrow spectrum antibiotics. And just in terms of things that are happening with this, then the NHS standard contract for acute trusts in 2023-24 included a requirement to reduce broad spectrum antibiotic prescribing by 10% from 2017. Only 23% of trusts actually met that target. And semi-structural interviews held with antimicrobial stewardship teams at high-performing and challenging trusts are being done to understand success factors and barriers, and thematic analysis of that is underway. So IV to oral switch, this is something I've had some involvement with in NHS England, but UK research indicates that up to 30% of intravenous antibiotic doses are unnecessary, and significant variation is evident across acute trusts. So as you will be aware, there's a whole range of reasons why it is important to switch to oral where appropriate. So you're going to have reduced length of stay, you're going to have reduced bloodstream infection. A potentially major thing is actually releasing nursing time, withdrawing up IV antibiotics, and of course improved patient experience. And a range of outputs and impacts here. So we've got a sort of nice editable infographic developed for the University Hospitals Birmingham, summarising the impact of IV antibiotics on organisations at ICB, region and national level. We've then got a suite of supporting resources provided on the future NHS website and national switch criteria published by UK HSA. And 98% of 117 trusts met the 2023-23 sequin target to have less than 40% of patients on IV beyond the switch point. And this is another thing where, again, having IT helping us can be useful. And a 1.14% reduction in IV doses per admission from 2023 to 2024, which is equivalent to 132 nursing whole-time equivalents with 20 minutes per dose. So just to flag this up again, I think you'll agree that we've got a lot going on in this area. I think we've all got a lot to be proud of that we're doing collectively to try and tackle antibiotic resistance and support antimicrobial stewardship. So we'll continue to push forward with our strategic goals, build on the behavioural change enablers, importantly the colleagues in the workforce, and also focus on those 9 different priority areas that I've mentioned. So the take-home messages. So we all need to play our part in confronting antimicrobial resistance, recognising that the burden of antimicrobial resistance continues to increase. It results in treatment failure and patient harm, as I've said earlier. It's quite shocking to see the numbers and proportion of infection-related deaths that are actually attributable or associated with antimicrobial resistance. And of course, we rely as a society on effective antibiotics, so everyone, including the public, has a role to play. And as you'll see, we've delivered an extensive program over 10 years to safeguard the effectiveness of antibiotics. And so we ask you to consider your contribution, for example, continuing to play your vital role in preventing transmission of infection, seeking out target training if that's appropriate to your role, prescribing shorter courses if you're a prescriber, promoting timely intravenous to oral switches if you're, again, in the appropriate environment, and supporting patients with recurrent infection, whereas I say there are strategies that you can use depending on the condition that can substantially reduce the need for antibiotics. So thank you very much.